All right, very good. Good morning. This is Susan Tilgner. I'm Franklin County Health Commissioner. Welcome to the Public Health Connection call for October. We want to welcome those of you who this is your first time on the call. We do these calls monthly. We try and come up with topics that would be of interest to you, all of you in our jurisdictions. It's helpful for you to know about what might be happening in public health and how it affects your jurisdiction. Today, we dedicated the entire agenda to Ebola, and many of you have been seeing all kinds of things in the news about Ebola, and we thought this would be a good opportunity to tell you a little bit about the situation with Ebola, what Franklin County Public Health is doing, how we're working with our partners, and how that might involve you down the road should that happen. So we're going to jump right into our agenda. And all right. First of all, I would like to also explain that we have Dr. Miller Sullivan on the phone with us, who is our medical director, and we have several staff in here who are going to be talking today. I'm going to start out with a very brief overview of Ebola, and very brief, because I know you probably all heard some of this and can read it in other places. But as you know, it's a virus. It was formerly Ebola hemorrhagic fever, and as a virus, that means there's no treatment or antibiotics for it. And it is something that was discovered in 1976 near the Ebola River in formerly Zaire, but that now is the Democratic Republic of the Congo in Africa. There's 5 identified Ebola strains, but 4 of them cause disease in humans, and you can see the names of the strains there. Obviously, Ebola is the one that we're dealing with now. There's also another strain that does not cause disease in humans. The natural reservoir host of Ebola is really not known, but the researchers believe that the virus is animal-borne and that bats are the most likely reservoir. And 4 of the 5 virus strains occur in an animal host native to Africa. So we don't have that same environment here, but there is an animal connection in Africa. I wanted to share with you some information. This is the most recent information from the World Health Organization, because I think it puts what we're dealing with in perspective. There are actually 5 areas that are dealing with Ebola globally. 3 of them you know of very significantly: Guinea, Liberia, and Sierra Leone. Those are West African countries where this epidemic is out of control, quite frankly, and the cases continue to climb. At the time of the data from the World Health Organization, you can see there were almost 9,000 cases with almost 4,500 deaths. That's 50% fatality rate, and depending on where you are and what the situation is, it could be a little bit more. Nigeria and Senegal, you may have heard about those 2 countries as well. They're actually approaching a time period where they've not had any potential contacts or probable or confirmed cases. So while there were cases that traveled to those areas, that seems to have be under control. And then finally, Spain and the United States continue to monitor potential contacts. Now, since 1976, there have been sporadic cases of Ebola in Africa. However, this outbreak is definitely the largest in history. You can go to the next slide. Thank you. Obviously, you want to know what symptoms are. Fever is something that's very important, but headache, muscle pain, weakness, diarrhea, vomiting, and most importantly, the unexplained hemorrhage or bleeding or bruising. Symptoms may appear anywhere from 2 to 21 days after exposure, but the average is 8 to 10 days. And when this slide was made, there's a temperature there, fever of 101.5. It's now changed, it's lowered to 100.4. But, I think the issue here is fever. And if it's something that you have a fever and it's something out of the ordinary, it's important to take a close look at that if you've been exposed to Ebola. So let's talk about that exposure and the transmission. It's spread through direct contact. So that means you actually physically have to touch another person. And it's spread through broken skin, mucous membrane, so for example, your eyes, your nose, your mouth. And the contact has to be with the body fluid, and you can see all the body fluids that are listed there from a person who is sick with Ebola. Also can come from being contaminated with needles and syringes, and again with infected animals. That is more of an issue in Africa. In the United States, Ebola is not spread through the air or by water or by food. And what's in contrast, when you think about the flu season, we're always talking about how you can spread it through the air, you can cough and sneeze on people, airborne transmission. That's not what this is. And the other piece that helps us control this outbreak a little bit better is that people aren't contagious until they start developing symptoms. So that helps us be able to pinpoint who might be sick and who might be contagious. Whereas with some of the colds or flu, people can be spreading it well before we know they've been exposed and they have it. Talking about close contact a little bit more specifically, especially as what we've heard about in the news with the patient that's traveled. When we talk about direct physical contact, it's what I described before. You actually have to physically touch the person who is actually confirmed with Ebola. And that ranges anywhere from the healthcare workers who are caring for patients, but you can also say that's any physical contact without protective gear. And usually when you have that situation, you're going to quarantine a person for 21 days. They take their temperature twice a day and they monitor symptoms. Because they have had that direct physical contact, you need to make sure that they don't develop symptoms, and you use that longest period of the incubation period, which is 21 days. Now, a little bit less easy to put into terms is close but no direct physical contact. So you can explain this in various different ways, but within a 3-foot radius for a prolonged period of time. Think about it as the travel on the plane that the people had with the person, or if you're in a car traveling with someone for a long time. In those cases, you take your temperature twice a day, you monitor for symptoms, and I would also say that you have to limit contact with others. And how exactly that is and in what capacity that is really up to the public health department investigating those cases, issuing quarantine and isolation, and evaluating what the risk could be of someone in close contact, their potential that they may get the disease as well. So, are you at risk? And this is really interesting because there are some people who are at risk. There is an outbreak going on in the world, and some people need to be very concerned. But 2 questions you need to ask yourself. In the last 21 days, have you traveled to Guinea, Liberia, or Sierra Leone? Or have you had close contact with a person known or suspected to have had Ebola? If you can answer no to either of those, chances are your risk is you don't have a risk of getting Ebola. But if you can answer yes, or there may be some situations where you don't even maybe know about the close contact piece, that's where things about isolation and quarantine come into play, and monitoring your symptoms for that 21-day period. Go to the next slide. And so that's what it leads us right into the epidemiology, finding cases and tracking contacts, which is exactly what the local public health department does every day. We do that for mumps, measles, pertussis. This is just on a different scale. And Radhika Iyer is going to talk to us about what we do to find cases and track contacts and what we would do in case of an Ebola. But before we go on, I want to ask if there's any questions so far. I'm sorry, Missy, go ahead.
There are a couple questions being posted. We will send the slides out to everyone. That will include the audio.
Okay, very good. All right. So with that, I'll turn it over to Radhika.
Thank you, Susan. Hello, this is Radhika Iyer from the Infectious Disease Program. I would like to give you a quick overview of how we find cases and how we do tracking of contacts. Next slide. Finding cases. Ebola virus disease is a Class A reportable disease. So what that means is anytime we suspect a case or someone walks in to the emergency room or are seeking care for their symptoms and Ebola is suspected for that individual, it would be reported immediately to the local public health. And basically the reporting is done based on where the patient is or living based on their address. So that would be the jurisdiction that would be notified. So anybody walking into any of the Central Ohio hospitals with possible Ebola would be notified to us. And, and we'll go from there to determine where exactly the patient lives or if they've traveled into this country or not. Then we use appropriate CDC guidelines and tools to determine if the individual meets the case definition, which is basically a combination of clinical symptoms and exposure. And Susan just provided a brief overview on that as well. We're looking at the exposure risk and also assessing what signs and symptoms you have to determine if this possibly could be a case. And then we also approve for laboratory testing, and that would be an approval that we would receive from the Ohio Department of Health to see if laboratory testing would be done on that specific individual. So while we're doing all of this public health case investigation, we also get a lot of details about obviously where the patient has been, but we also isolate the patient. We also identify contacts and we quarantine the contacts. And I'll go over more details here in the slides coming up. Next slide. For the isolation of the case, the Ohio Administrative Code allows us to isolate the case, and basically a person with a confirmed or suspected viral hemorrhagic fever here, but Ebola virus disease will be placed in airborne isolation. And most individuals are in a hospital setting, so that's being taken care of. And then I think we have slides moving forward that will explain further public health authority on isolation and quarantine as well. So quarantine of contacts. We can identify all the close contacts when we're doing our public health investigation. And basically we're looking at that 3-week time period, the 21 days after the onset of the illness for the index case, which is our first case that we know of and any contacts from that individual. And we would initiate quarantine for the contact at that point. And then part of the quarantine for contacts, we initiate active surveillance of contacts. We take, obviously complete information about their whereabouts and where they live and all of their medical information as far as if they're exhibiting any signs and symptoms or not. But what we ask them to do is to take and maintain record body temperature twice a day for 3 weeks after their last exposure. And if that temperature is greater than 100.4, again, a correction on the slide with the 101, we would ask that patient to, or that individual to seek medical attention. And also, again, that person would be placed on isolation because if they become a case, then the cycle continues. We isolate the case and they quarantine the contacts. Next slide. So due to the current situation in Ohio, this is brand new information just released from the Ohio Department of Health today. Ohio is actually doing enhanced quarantine protocol, much more detailed and different than what's been put out there by Center for Disease Control and Prevention at this point. So I'll just quickly go over this with you and basically for the direct physical contact with the index case, which means you have you've done a handshake with this individual without proper PPE, which is the personal protective equipment, that individual will be quarantined for 21 days after their last contact with the individual. So that's pretty clear cut in this situation. This is brand new, like I said, and we're still trying to work out the details of how that's going to be. But this is specific to Ohio and very much needed at this point based on the situation up in Akron. Next slide. The other piece of the enhanced quarantine protocol without direct contact, which is within a 3-foot radius of the index case, like traveling on a plane or in a car for a prolonged period of time, we will be asking those individuals to do temperature checks twice daily for 21 days after that last contact. Again, much more detailed follow through on that, and we're still working out the details of how we're going to follow through on that. The last piece of the enhanced protocol, next slide, is without direct contact, but in the vicinity of the index case, we would require notification and self-monitoring, and the notification is to public health. So if this individual meets this criteria, they would have to notify public health and they would monitor their temperature. And any of these situations, anytime an individual starts symptoms, they are expected to follow through with their healthcare provider or call 911 and let them know about their exposure before the personnel come in to show up to pick up the patient.
Okay, and I know we have one question. It's a long one, but it's a good one. When you initiate quarantine, what will this logistically look like? Where will they be quarantined? Will we need to have locations predetermined for potential usage of our pre-hospital care providers? And if so, what are the requirements of a location to be used for isolation? I'm going to go through a few of those at a time, and some of that will be covered in the next section on the isolation and quarantine. So I'll start there and then we'll move on.
Good morning, everybody. It's Mitzi Klein, Communication Director. I just wanted to add a couple things to what Radhika talked about, to put it in perspective with the events of yesterday and the travel of the nurse who was confirmed with Ebola out of Africa, or out of Akron. I apologize. She did spend some time up there, and as you likely heard on the news, the CDC requested the flight manifest for everybody who was on the flight. That is being reviewed, and if there is a case in our jurisdiction, we will be notified. That has not happened at this time, so we do not have any reason to believe any of that is here local, but we are monitoring it very closely. In addition, I just wanted to share that you've heard us talk on previous months about our infectious disease reporting system. We have that system in place 24 hours a day, 7 days a week, 365 days a year, and our hospital partners know to call us directly anytime there's a suspected case of Ebola. So our channels are open and we are monitoring things very closely.
Okay, very good. All right. Let me go into isolation quarantine and then we'll get to a few of the questions that are on there about contact. This section is called isolation quarantine, planning with our law enforcement partners, because as you can imagine, they play a very big role in this. First of all, the difference between isolation and quarantine. Isolation is the separation of people who are already ill so that they don't spread to other people. So if you know someone has Ebola, you isolate them from others. Quarantine applies to people who've been exposed to a contagious illness or potentially been exposed, and they may be infected, but we don't know that yet because they're not ill. And so what you do is you place them in quarantine, which is the same thing. You separate them, restrict their movement, so that should they end up developing the disease, they can't spread it anymore. Next slide. So the authority for isolation and quarantine is given by the Ohio Revised Code. The Board of Health has the authority, and they have designated, and there are certain circumstances that the health commissioner can issue isolation and quarantine. And most likely the health commissioner will be doing that because the criteria are, it would take to, the Board of Health has to get together for a meeting. They have to be able to meet and make those declarations. And most of the time that cannot be done in a timely manner when you're talking about a communicable disease. So the health commissioner has been designated by the Board of Health to go ahead and issue isolation and quarantine orders. We are working with the Franklin County Prosecutor's Office and our legal counsel to have those templates in place already so that if we do need to issue those orders, we're ready to do that. Isolation and quarantine is about, in the code, it talks about restricting exposed persons to their place of residence or other such suitable place. So when on the question, where would people be quarantined? Usually when you're talking isolation, as Radhika mentioned, you have an ill person, and most of the time, especially with Ebola, that makes people very ill, they're going to be in a hospital setting. Others may, for example, the quarantine, you're going to see that they're quarantined in their homes. And that's fine as long as they can stay in their homes and they observe the quarantine orders. There's also in the code the ability to placard premises. So you can say this premises is quarantined, so people know not to go into it. And then also you can employ quarantine guards. And if you remember seeing on the news, the Dallas police and law enforcement being involved in that, that in Ohio, the health department can employ quarantine guards. And the Franklin County Sheriff's Office has agreed to work with us on that issue. And we're also going to coordinate that with Columbus Public Health and Columbus Police Department. And then also the other law enforcement. Those things are already in the works. There are meetings already being set up to talk about how that would happen. Now, you also may have heard on the news, most people voluntarily quarantine themselves, or they agree to the quarantine orders. Doesn't mean you don't trust that implicitly, you still check up on it. But a lot of times people want to do the right thing and not infect other people if they should be ill. But in extreme circumstances, we can employ quarantine guards, which is law enforcement, and they can take whatever means necessary to keep that person from moving out into the general public. The problem with some of the quarantine places, for example, I see on there's a question about assigned locations. Is there a way to scroll back up to the first part of that question so I can make sure I'm way up above? There we go. Okay, so I think we talked about logistically what this would look like. Our infectious disease program would identify that someone needs to be quarantined. The health commissioner will issue that quarantine order, and then we will be able to make sure that we find the location, hopefully if they need healthcare in a healthcare facility or in a home. There's a whole nother issue for pre-hospital transport. And Debbie, are you going to touch on that a little bit in your section?
Yeah.
Okay, so we'll get to that in a little bit. And then in terms of the requirements of a location to be used for isolation, if a person is ill, they have to be able to adequately treat that patient and also treat that patient in a way that protects the healthcare workers who are taking care of them or the facility and those kinds of things. And as you know, there's a lot in the news about whether or not what kinds of things are necessary for that to be done and where those places should be. A lot of discussion happening, and we are also having some of those discussions with the hospitals that I think that we will touch on a little bit. I want to make sure I covered all of that at this time. Okay. All right, so we'll go on to the next section, which is talking about Ebola and pets. And then we'll circle back around. We'll have Debbie talk about the healthcare piece after that, and then we'll circle back around and make sure that we've caught all those questions that are on the board and any other questions we might have. So Charlie Brochard is going to talk about pets. It's also been introduced.
Thank you, Susan. Good morning. We're going to switch gears a little bit, go away from the human side and look about the concern with pets. As you may have heard, what happened in Spain, they euthanized an animal that they thought had exposure. We have a pet that was exposed in Dallas. So there's concern whether animals will be a possible reservoir for Ebola. What's currently being done, CDC, U.S. Department of Agriculture, the AVMA, and the National Association of State Public Health Veterinarians are working on a policy and guidelines to address pets that have been within a household or had contact with someone that has Ebola. Those are constantly coming out with development. They started off, I think Monday was the first update we had. So that's going to continue, and we'll get some more information. That is on CDC's website. There's a little button you can push that shows Ebola in pets. So CDC's released some stuff, and they're going to continue to do some as this work group continues. So we've got some guidance, and we're going to kind of see what happens from here on out. Can pets be infected? Well, first of all, the animals that we are certain that can carry Ebola are monkeys, apes, and fruit bats. That comes basically from the information out of Africa that those mammals can carry the disease and are infected with it. Currently, there's no reports of dogs or cats being infected with Ebola, meaning infected, meaning they have full-blown symptoms and can possibly be contagious. There is a little bit of limited evidence of a study that was conducted in 2003 that it's possible that they could have the infection, but it doesn't develop into the disease. So that's why we're being cautious with these pets, simply because we're not sure whether that can be spread from the little wet snoot of the dog or from cleaning up their urine or feces. So that's precautionary at this point. But at this point, it looks like pets could be asymptomatic. That means they don't necessarily go into full-blown symptoms, but they could potentially they could be a disease carrier. And quickly, what our next steps are, we're going to continue to follow and monitor what CDC is coming out with along with that work group. We're going to watch and see what's going on in Dallas with that quarantine process with that animal. We're sharing information currently with the Franklin County Commissioners and Franklin County Dog Warden. As we get information, we share that with them since they may be one of the primary people that respond to dogs at this point. The next part is we do have the authority to quarantine animals. That authority of the quarantine, just like a person, we have that ability to do that with animals as well to prevent the spread of disease. So that will look very similar, where maybe a 21-day quarantine, maybe very much inside somebody's home. We're going to continue to look at those possibilities at the terms of quarantine as well. And then we're also going to bring some other animal agencies, Capital Humane Society, to the discussion. I've been in contact with veterinarians at the Ohio State University as far as their offices and their public health department as well, or their public health school, to find out what they know as we go through. So we'll keep exploring this information as it comes through, and we'll hopefully develop some pretty good guidelines if that happens in our jurisdiction.
Any questions for Charlie at this point? Okay, I hope I don't cause our PowerPoint people too much trouble, but I think I'm going to go to Debbie to talk about the hospital issues and pre-hospital issues and make sure, I don't know that we have a lot of answers, but we do have a lot of efforts to get people together to talk and get some answers. So I'm going to turn it over to Debbie Wright, who's our Assistant Health Commissioner and Director of Nursing, to talk about hospitals and other partners.
Thank you, Susan. Good morning, everyone. I just want to talk very briefly on our activities and actions that we're taking on right now with our hospitals, as well as other partners in the community. Currently, the 4 major hospital systems in Franklin County are having conversations among themselves, bringing in Columbus Public Health as well as Franklin County Public Health to those discussions to determine what the strategies will be if someone in the community develops the infection. They're reviewing infection control procedures, taking stock of their supplies of personal protective equipment. They're training and educating their staff, and they're in the process of utilizing some checklists and guidance developed by the Ohio Department of Health from the guidance from the CDC. So right now, they're all planning and doing a lot of preparedness around being prepared if someone presents with an infection. The point I want to talk about also is we are also in conversations with law enforcement as well as the fire chief to talk about what measures EMS needs to take around transporting a patient. And one of the big issues is making sure that before someone is dispatched to a call from someone that may be potentially ill, is to do a bit of screening on the phone with them to determine whether or not they may be ill with some of the symptoms of the disease. And so there is conversation again going on about what that might look like, what are those questions, and we're in the process of working here to develop guidance and screening tools for not only EMS, but as well county agencies and other providers of services in the community that would potentially be in touch with a person that may have symptoms of Ebola. So,
and I just want to pick up on a couple of questions that I'm seeing there. One of them is Are those who have had contact supposed to go to an assigned location rather than potentially exposing others at urgent care or local ER or assigned to a certain hospital? You know, that's part of the discussions with the hospital systems. And I also know that that's also one of the questions about if that is not a life-threatening situation, what kind of call ahead can be done so that these people are prepared when on the other end when someone who potentially has Ebola is coming into that location. So I think that's some of the conversations that are still need to be had in terms of the healthcare system. And then there's also I think it also, that question says, should we refer to a specific location? Again, I think it's, at this point, that has not been set up.
Correct.
And it, you know, I think the understanding is that everyone will be prepared to do that, but hospitals are having that discussion about how that would work. Okay, do you recommend any new protocols for organizations with public waiting rooms, restrooms who serve diverse populations? At this point, no. I mean, our general infection control issues, we've talked about a screening tool to determine if there's that people who may be symptomatic, who might have risks. But I think we're also talking about that tool that we're still in the development of, but they'd have to make sure that they ask everyone the exact same questions and not to single anyone out in those situations. So really, in a lot of those public waiting rooms and places like that, it falls back to a lot of the basic infection control procedures that we're asking people to do, whether it's about the flu or things like that. And especially in this case, since it is not an airborne, we're hoping that limited time is something that they're not at quite risk. Do the fire systems need to be treated the same as Ebola until it's ruled out? Flu symptoms. Oh, I'm sorry, flu symptoms. Debbie, I don't know if you want to answer that one about flu symptoms.
As you heard earlier, the symptoms of influenza are very similar to the initial symptoms of Ebola, in that you can have fever, headaches, body aches, not wanting to eat, that type of thing. So at this point in time, that's not a recommendation as far as isolating everyone who may have some symptoms of flu. But again, it's to monitor yourself and make sure that you're taking your temperature. And if you have any questions, to contact local public health or your healthcare provider.
And I think it's getting back to those two questions about risk. It's really about the travel, and it's really about exposure to known person who's known to have Ebola. Let's see, employment of quarantine guards would have a huge impact on local law enforcement if multiple people were to be quarantined. What do you do with the person who fails to comply? Absolutely, it would have a huge impact on law enforcement and public health as well, and probably some other symptoms. I think the issue there is that we're still having those conversations with law enforcement. I think any community across the United States would find that this is going to tax things. We've already started, as I said, we've started conversations with the Franklin County Sheriff's Office, and things are set up to be meeting with the police chiefs and reaching out to all the law enforcement in the area, talking about how we might be able to utilize MOUs. But at this point, we're willing to still have those conversations and see how that would happen. And answering that question, what do you do with a person who fails to comply? In a situation where a person has a deadly, dangerous, communicable disease, and they are not willing to comply and potentially infect anyone else, the Ohio Revised Code says we can use whatever means is necessary. I hope we never get to that point. Some of the experience so far is that that has not been the case. And so hopefully that will continue to be the case. Can I please go to my next slide? Okay, go to the next one, I'm sorry. So that this kind of brings to what we can be doing, and it feeds into a little bit of this. I think for me, it's about three different things for us in Franklin County and the Central Ohio area. First of all, it's about taking care of healthcare workers and others who take care of those who are ill. So in other words, making sure that the training, the equipment, and the right PPE is available to those who are taking care of someone who has Ebola. This is going to be a hospital setting most of the time. We need to use the tools of isolation and quarantine judiciously. Ebola is an interesting one because, in the flu, isolation and quarantine doesn't work because people can be infectious before you know about it, and they can be out spreading it around. And that isn't the best way to stem those infectious diseases. And we have a tool like a vaccine. In this case, when people become symptomatic, because that's when they can start being contagious, the tools of isolation and quarantine work very well. And so we're going to take that very seriously here. And as we evaluate the cases and when we get a case and the contacts, we're going to be very judicious in using those tools to make sure that we can stop the spread. And then I think finally, and most importantly, is frequent and transparent information and communication about Ebola. There are people in this country who are right to be concerned. They've been exposed to someone or they've been in contact with someone who now is ill. They should be concerned and they need to do things. However, for most of us, we're still this is something we need to be prepared for. We need to make sure that we're ready, learn the lessons that they're learning out of Dallas so that we don't repeat those things. But I think important information and transparent communication is most important. I'm going to make sure, and if I don't get to every question, please let me know because I'm trying to make sure that we do. Let's see. Deployment of quarantine. Okay, where are we? I can't read it when you. That's okay. That's okay. Has there been an outreach to let people know that Somalia is not in West Africa? I think people have a misconception about our Somali immigrant community. I hate to see them singled out. We actually hate to see any community singled out, but actually last night in particular, we had some discussions with one of the community groups. So I don't know if it's Misty or Ben wants to talk about that. Right,
This is Ben Robinson. I'm the EP supervisor here at Franklin County Public Health. We had an opportunity to meet with ETSS, which is an organization that serves a number of immigrant communities here in Franklin County area, as well as other places in Central Ohio. And we expressed similar concerns that we don't want to see any stigmatization occurring. We want to reiterate the message that the country of origin is not of concern in terms of transmission. What is of concern in terms of transmission is contact with an area that has an uncontained Ebola outbreak, or contact with someone who has been or may have possibly been exposed to Ebola. So a person who is here from another country, regardless of regardless of the country of origin, if they have been in the United States for 21 days, they are no risk to the community. And in fact, they are a resource for us, an opportunity to come alongside to do planning and partnership. In fact, our talks last night with ETSS were incredibly productive, and they have mobilized the immigrant communities throughout Franklin County. And in fact, those communities are perhaps better poised than others to disseminate information and to ensure their communities are prepared.
Very good. And then I know from Commissioner Brooks, you asked about with Airborne is not rolled out. Are you in touch with Pentagon leadership? Actually, our connections are through the Ohio Department of Health, the Centers for Disease Control, and our subject matter experts through universities. We have some very good subject matter experts here in Franklin County with Battelle, universities, and things like that. So that's who we rely on for our subject matter expertise. And I think there may be lots of places for improvement, but communication is one that I think is working very well right now. When can we expect an answer from the collaborated efforts of the local hospital systems relative to the regional center, like terminology to be used on the radio hospital report and any potential additional patient packaging requirements? Debbie, were you going to respond to that one?
I was just going to say that those conversations are happening yet this week, and so as soon as we have more information, we will make sure everybody gets that information.
And that is a big area. The pre-hospital system, fire and EMS, is one big area that we could spend a couple hours on this call. So that's one area that we go through this, that really we have to have some more discussions, that law enforcement on the quarantine. Also on the quarantine, I think there was a question about who provides for those in quarantine. The Ohio Revised Code says that if we put someone in quarantine or isolation, and we're responsible for providing for them. Well, you can imagine that, you know, just like employing the quarantine guards is a huge issue with resources, that would be an incredible resource on public health, resource drain on public health as well. But it is the way it is. If we quarantine someone and they do not want to stay in quarantine, we are required to provide for their daily living needs, their medications, whatever kinds of things are necessary so that they can be in quarantine. Okay, let's see. Has there been any discussion or consideration regarding the possibility of a martyr intentionally contracting and then spreading the disease? I have not heard of anything like that. I'm sure there are people that are talking about that. I think, you know, we work with our partners in the county that have the expertise on bioterrorism and that kind of thing. So we have a fusion center here, the state fusion center is here, and all those kinds of things. We participate in those, you know, the Homeland Security Advisory Committee. I guess what I'm saying, they're the experts who would know about that kind of thing, if there are things out there being considered, and we look to them to give us advice on that. But for now, really, this would be a difficult one because you are symptomatic before you can spread the disease. Okay, is there anyone on the phone who has some questions? Okay, and I see there's a definite question about definition of prolonged contact if we have clients with staff in a combined office. You know, that's what's very difficult to pinpoint. You know, using as the kind of, you know, one of the things with the plane ride, with, you know, we can kind of get our heads around that. How long does it take to fly from Cleveland to Dallas? That would be considered prolonged contact. But usually sitting in a chair with someone for a little while and you're not touching them, you don't have any direct contact with them, and they have no symptoms, that's a very low risk. I would not say it's a no risk, I'd say it's a very low risk. But again, all of these things, and when we do infectious disease investigations and our infectious disease epidemiologists and nurses talk to people, no two situations are ever the same, and you have to really take in all that information and look at it. But I would say if you are seeing clients that are coming in for services like they always do, again, it falls back to your general infection control precautions. No physical contact, making sure that you're washing your hands and you're doing some good cleaning of your office space and your facility. How do we respond to someone who's had a flu shot and thinks he was proactive? That was proactive step, and
That was a proactive step.
that was a proactive step. Oh, and safe from Ebola. If that's what you mean, it really, flu shot helps for the flu, and it helps the healthcare providers to be able to say, you know, maybe we can rule out that that's something, confounding how to make a diagnosis. But I think it's really important. We want people to get their flu shot. We want them to have one less thing to worry about. But really, a healthcare professional is the one that's going to have to make that diagnosis. And, you know, we can't do that.
And then there is a question about screening tool, and that is in the works right now, and we're developing questions and a checklist for entities that would be in contact with the public who can ask those questions and help them determine what their next step is. So that will be forthcoming within the next few days.
Okay, and then the next question is about public awareness tools, because it's about what you can share with employees and agencies. We want you to share all kinds of information. So we're going to go back to Mitzi's presentation now, the last presentation of the morning, and you can talk about how we're going to help people do that.
Sure, thanks, Susan. Hi, good morning, everybody. As you can imagine, education and the facts are going to be key in keeping people calm and understanding what's going on. So we want to do our best to be that source of information for you. So what we've done is we've created a couple different educational flyers. Okay, yeah, the graphics of those aren't showing up for some reason. But anyway, we have an 8.5 by 11 educational flyer as well. That's an Ebola fact sheet, really, that you can use and you can distribute to your residents, to your customers, to your clients. So we have that available to you electronically, but we also can provide you hard copies of these fact sheets. So to request those hard copies or the electronic copy, I put Amber's contact information up here. If you want to call her or email her, we will send you quantities. All of our jurisdictions, our municipalities we serve, the county offices, I know, have been seeking information. So these will be good for you, good tools for you to help explain the situation and understand the situation. So I encourage you to give us a call and let us get that information in your hands. We've also set up an informational hotline here. Now, you likely heard on the news that the Ohio Department of Health also opened a call center. People certainly are welcome to call that, but we do have a hotline, and this is for folks who have questions about Ebola. That number is 525-3097. Also, on another note, yesterday we did open our Department Operations Center. So for our partners and stakeholders, let me give you a phone number. This is not on the slide, but I want to give you the phone number of our liaison, who is Shadi Swade. And we will send this out in the notes afterwards, and I'll make sure that you have this number because we want you to call our liaison with any questions you have. The direct number for him is 614-525-4261. Again, 525-4261. Because I know there's a lot of questions on here that we may not have answered as much as you like, and we may have missed some things. So as our liaison in our Department Operations Center, we encourage you to reach out to us. But for the general public and those with symptom questions in that, our informational hotline, the 3097, is what we would like for them to call. Now, we also encourage you to visit our website. We have links to many CDC documents. The flyers are also on there. But if you want to put information on your website to help get information out to your residents, please link to us so they can get constant and consistent information. Our goal here is to be transparent and timely. We want to let you know, and we will let you know what we know when we know it. So for right now, we do not have a case here. We wanted you to know today we are doing an immense amount of planning and preparedness. Now, this didn't just start this week. This has been going on for months, but as you can imagine, once the situation hit Dallas, and then certainly here with the link and connection to Ohio, that has certainly increased the amount of time that we're spending and what we're doing. So as you heard, we have done direct outreach to the special populations. The African community meeting last night was amazing. They had the leaders from so many different key groups that are going to be essential to get information to. And we want to develop that relationship with them so they know to call us if they have family members coming into the country or who may be going to visit family in one of those high-risk countries. So anyway, so that's going on. We're continuing to do an immense amount of work. Oh, I neglected to mention that our flyers are also available in French because from what we have learned, African French is what is spoken in the Guinea, Liberia, and Sierra Leone areas. So we are working to get it translated into other languages, but as of today, we have English and French. So when you request information from Amber, if you could let us know which version you would prefer, that would be great. So with you, like I said, we want you to communicate with us through our liaison, or really any of us are available to you, our partners. The general public is key, and the media, as you can imagine, are knocking hard, asking all kinds of questions. We actually are doing an ABC6 call-in bank tonight, and Susan was on Sunny 95 this morning. We had some covers last night. So we are making ourselves very available to the media as well because we want them to hear from us and know locally what's going on. So on a final note, our incident commander in our Department Operations Center has been Robinson. You just heard from him.
Yeah, and that was an answer to one of the questions, have we initiated ICS? And yes, we have, so, we've done that. There's also a question from Westerville Division of Fire, it's actually two very good questions about recommended PPE and, EMS crew, if they feel they've been exposed, what they should do to not take this home to their family. I don't know if Ben or Debbie, I mean, I think these conversations are still happening. If you can respond to that, that'd be great.
Sure, this is Ben Robinson again. With regard to the first question, we would encourage you to follow the guidance that's available on PPE for protection against Ebola. However, we just want to reiterate that we're not currently in a situation in which Ebola is endemic in our community. And much of the guidance for EMS agencies assumes that Ebola has been identified in the community before taking those additional steps. We recognize that there are concerns and questions about whether we should take additional precautions earlier than that. And so we are forming a committee that represents a number of disciplines, along with key decision makers in those disciplines who can speak to whether policies could be implemented perhaps in a more expeditious manner than what is currently being recommended. But as of right now, we would encourage you to use the CDC guidance with regard to PPE as well as EMS precautions that are being recommended in accordance with our current situation.
Go ahead, Ben.
With regard to the second question about EMS crew and steps they can take to protect their family, we actually received this question yesterday from EMA as well, and we've begun to work on a protocol for that. In very short description, there are essentially two components. One is proper hygiene after a time in the field, and then potential steps for quarantine and how to do that successfully. Obviously, we want to be involved in that, and if anything were to happen like this, we are always available to receive phone calls. You can always call and consult with us, and that will also be part of the developed protocol. But we recognize the need for this, and we're working closely with our partners in both the medical and EMS field to ensure this protocol is available.
And if someone has an interest in serving on that committee or at least being involved in some way, I would suggest that you contact Ben, because you are the subject matter experts for pre-hospital and EMS. We're willing to facilitate that and help provide whatever resources we can. And this is one of the ways we're doing that, trying to get the interested parties together to come up with something that works for everyone. So if you have an interest, contact Ben, and we'll be glad to have your input for sure. Debbie, do you have anything else to add? Okay. Are there any other questions? And did I miss something in the questions along the way? Okay, we've taken a little more of your time this month than we usually do. However, I think these were all good questions. I think to let you know that we are willing to do the things that we need to do in public health. We want to make sure that we are reaching out to all of you, especially those who can provide us with very good information and how to coordinate that. And to let you know that, we have some very good response partners. As you all know, you're all part of that response. And we want to stay calm and do the best we can and learn from the lessons that are happening in Dallas. So let us know what else we can do to help you. Let us know what other information you want. And if you'd like another call before our next month's call, we will obviously set that up as well. But thank you for your attention today. And again, let us know what you need and we'll try and do the best we can. Thank you. Yeah. Thank you.